So I'm Ashlyn Thomason, and I'm here with Beth Nutt and Emily Pankey, and we are presenting speech findings from 2017 SATB2 Association Syndrome Clinic. So SATB2 is a really speech-heavy syndrome. All right, so when we were reading about SATB2, we were hearing things about cleft palate, which involves speech, feeding, language, intellectual disability, pharyngeal dysphagia. And so we thought, gosh, we have 30 minutes to get so much information about these kids, but we were up for the challenge. So many of you are in speech therapy and you realize that speech pathologists can test your kids for hours and hours and hours, and that's really what we would have preferred to do. But we used our limited amount of time to get as much data as we could. Some of the data that we got came from pieces of formal tests. We gave a receptive language formal test, sub-test to get some information there, and a formal screening tool for apraxia of speech. And then some of what we got was from parent report and from observations. You'll see throughout our slides in our diagrams that show our data that N, the number of subjects that are included to answer any particular question, sort of changes. And that's because sometimes we did not get data from some particular kids. Maybe they weren't able to participate in the testing, or we forgot in all of our rigmarole of getting information about those kids to include that particular question. So you'll see that changes. We had some really big picture questions that we wanted to answer when it comes to the speech, language, and feeding needs of kids with SAS. We wanted to know if these kids plateau. With other syndromes that are associated with intellectual disability, we see that a lot of times kids will get to a certain language level and they're just kind of there throughout adulthood. And we wanted to know if that happens with SAS. We also wanted to know if there was any particular impact when it comes to the mutation types among our subset of kids with SAS. Does mutation type matter when it comes to any of these particular domains? And we want to guide you guys so that you know about how to be most successful in therapy after seeing all of these kids and seeing what works with them. How can we give that information back to you guys in a good way that will benefit you in therapy? So I'm going to start off today talking about language. So we gathered information about how these kids communicate, and it's quite a variety. So not everyone is just a verbal speaker. These kids are using signs and AAC and gestures, and we wanted to glean some information about how these kids are most effective. We wanted information about how often we can expect these kids to be primarily verbal communicators versus not. We wanted information about their receptive language, which is how much they're understanding, in addition to their expressive language, how they're able to get messages across to the outside world. We used a scale to rate their overall communication ability, how they are sending and receiving messages in a big global way. We want to know when we can expect these kids to begin talking. And we also had some findings about increased autism prevalence among kids with SAS. So let's start off with modes of communication. So for our kids with SAS, 42% of them go to gestures most often. Second to that, we have kids who are going to go to verbal speech most often. But within our subset of kids with SAS, we have kids who are using AAC, gestures and signs, and then some kids who are using non-word vocalizations like grunting. When we break it down to kids who are primarily verbal versus kids who are primarily nonverbal, that breakdown comes to 41% of kids using verbal speech and 59% who really aren't using much. It's very tough to define verbal versus nonverbal, but for our purposes, we chose kids to be in the verbal category who had really more than 10 words and used words as their primary mode most often. And for those kids that we were considering more primary nonverbal speakers, they were usually using another modality of communication more often, and they had generally 10 words or less. We wanted to know if there was any effect when it comes to mutation type in our kids who are primarily verbal versus primarily nonverbal. So you'll see that it really didn't. So we have divided our groups. We got data from Dr. Zarate on our large deletions, truncating, intragenic, missense, and duplications. And so you can see for our kids with those types of mutations for verbal versus nonverbal, both sets of kids fall into both sets of categories regardless of their mutation type. So there wasn't a huge effect there when it comes to being a primarily verbal communicator when it comes to the mutation. So then we gave a receptive vocabulary subtest of the TACL, the test for auditory comprehension of language. So we would show your kids 3 pictures and tell them a vocabulary word and see if they could identify that vocabulary word by pointing to that particular picture and correctly identifying it. The words started out pretty basic, words like nose and boat, and then increased in complexity to words like descending or board. And so we got a raw score, just how many of these words can these kids identify. And so our raw score really gives us a good range of scores as compared to a scaled score, which will just tell us how they compare to their peers. So we put this data together by looking at our kids by age. So we have kids here who are as young as 27 months and kids here who were as old as 247 months, 20 years. And then we have the number of vocabulary words that they were able to identify. Ignore those lines going across the page. I couldn't get rid of those. Those represent kids who were the same age with the same type of mutation. All right? And so this arrangement of our data allows us to see if our kids plateau. So we would see with age in plateauing that the number of their vocabulary words kind of stayed the same at a certain point, but that's not true with kids with SAS. All right, so you can see that the general trend is that younger kids knew less words, and as kids got older, they were acquiring more and more receptive vocabulary as a group. Of course, we have some kids who really struggled in the area of receptive vocabulary and some kids who really excelled, but the overall trend is that these kids don't top out. They can continue to learn more and more vocabulary words. And you see once again that the mutation type is kind of all over the board. So our average number of words identified on the TACL correctly was 9.7. For each mutation type, you can see here how the kids did. So our truncating mutation, kids identified the most words, but there really isn't a large range there. And when you consider there were only 2 kids as a part of the clinic who had a duplication, you can see that just having a small number of kids can sometimes inflate the data a little bit. So then we needed to look at that same information, their scores on that TACL expressive vocabulary test, and see how they look compared to their same age peers. And so that's a scaled score. And so when we put their scaled score, how they stack up compared to other kids, we see sort of the opposite effect. So a scaled score of 6 is only a mild deficit compared to peers, but a scaled score of 1 is a severe deficit, 5 being moderate. We have some kids who got a scaled score of less than 1 is how that kind of came out when we compared them to peers. And so we see that younger kids with SAS were more likely to be closer to their same age peers in functioning. But as the kids got older, their growth in their receptive vocabulary wasn't as accelerated to keep up with their peers. All right, so then we wanted to look at expression of language. We asked parents of our children who are verbal communicators and children who were not verbal communicators, how many words does your child use? And we wanted to look at that relative to age. And so we see that there's quite a variety. There are kids here who of course are using no words, and there was a child here who was using close to 200 words expressively. And this is with spoken language, not with AAC, not with signs or with a tablet device. And so for a lot of our kids, that average length comes out to about 1.57 when it comes to utterance length, but let me go back to here because I wanted to talk about plateauing. So it does look like generally our kids have under 50 words, a lot of kids around 10 words, but there are some kids who do better. When it comes to mutation type, again, it's sort of all over the board, but some of our higher functioning kids had truncating deletions, and then our highest had a missense mutation. We looked at utterance length. How long are the messages that kids are putting together? And so is it just one word? Can they put together some 3 and 4 word sentences, as we saw with a couple of our kids last year? So the average utterance length for our kids who are primarily verbal communicators, we did not include the kids who generally use 0 words, was 1.57 units within their utterances. And that ranged from 1 to 4, and that included 37 kids. We used a scale that looked at a child's ability as an overall communicator. This is an international scale called the Communication Function Classification System. So this classification system takes into account communication modalities like AAC, and it rates people on a scale of 1, meaning that they are a reliable sender and receiver of messages, with even an unfamiliar communication partner. So people like most of us in the room, they can walk up to someone that we don't know and we can understand them and get our message across. All the way down to people who struggle to get a message across even with a familiar partner. So a child's trying to tell mom and dad something and they're having to guess and guess and guess and guess as to what that message might be. And so you know that even with AAC, a person who's using sign language or a tablet, they can be an effective sender and receiver of messages. And so this takes AAC into account as well. So it's a little misleading with how this graph is done, but a higher function is at the 1 and the lower is at 5. And so we looked at that by age. Again, these kids really aren't plateauing. Mutation type didn't seem to matter, but a lot of our kids did fall in that 4 to 5 range on the lower end of the scale as far as having trouble getting messages across to even familiar listeners. We ask about acquisition of or about the age at which kids said their first words. The average that we got from parents was 29.9 months. We had a child here who said his first word at 8 months of age, and a child here who said their first word at 66 months. We also found that there's a higher prevalence of autism among children with SAS. So 81% of the kids seen in clinic last year did not have autism. 13.5% had a diagnosis of autism, but then there was this other 5% that our team strongly felt had an autism spectrum disorder. At least in the state of Arkansas, to get a diagnosis of autism, you have to have testing from 3 different professionals: a pediatrician, a neuropsychological examiner, and a speech-language pathologist. For these 2 kids that we identified as likely having autism, we consulted with our neuropsychological examiner and looked at our speech data and our clinical impressions and said, you know, we really feel like these 2 kids should also be included in that group who have autism. So we're considering them a clinical diagnosis. So when it comes to autism prevalence among kids with SAS, mutation type did seem to matter. So we had 3 kids here with missense mutations who had a diagnosis of autism, but those 2 additional children that we saw that we strongly felt had autism also had missense mutations, but we had a child here with autism with a large deletion and a truncating deletion, or a truncating mutation. So before I turn it over to Emily Pankey to talk about feeding, I just want to see if you guys will join me in thanking Emily. Emily is our graduate clinician. She has spent hours and hours and hours in an Excel spreadsheet getting so much data, just boring hours, collecting all of this for us so that we could put it together in a way that's really understandable. She babysat your kids last year. She was running us testing books and cups and candy. And so join me in thanking Emily Pankey for her hard work.
Let's see here. Oh. It sneaks up on me. You guys are so sweet. Thank you. We'll find a place for it.
I can just hold it. There you go.
Just don't look back there. Okay, so my name's Emily, and you guys have been so easy to work with and just so fun. I admire your community that you have together, and just being in this room, it's easy to see how much you support each other. And so even though I had one of the boring jobs of going through all the data, I remembered meeting a lot of the kids last year with the child life kind of people that we worked with. And so although we have a lot of new people here, there are some of you that I got to meet last year. So when it comes to feeding with this population, a lot of families really mentioned drooling, overstuffing or pocketing food during the meals, and pharyngeal dysphagia, and that's just a fancy way of saying some swallowing difficulty. And so of those that reported drooling, there were 62% of those children, of the 37 that we saw last year, 62% of those children were reported as drooling, and 38% reported no drooling at all. And of those that did report drooling, some even remarked that the drooling had stopped completely or had over time it had improved. And of the kids whose drooling stopped, the average reported age that it stopped completely was 48.1 months, or around 4 years. And under that 48 months, there were 8 kids that were still reported as drooling, and 12 kids over the 48 months that were still drooling a little bit, but it had but then the 4 of the 12 reported that drooling has significantly improved. Sorry, numbers are really not my deal, so sorry about that. So even though drooling is a large portion of this, we did see some improvement and also some that stopped completely. And of the overstuffing that was reported during the meal times or during feedings, 66% of those 35 children, there was overstuffing reported, and then 34% of those reported no overstuffing, excuse me. And as far as the problems with the swallowing or the signs of aspiration, out of those 37 children that were seen in the clinic last year, 76% of those no signs were reported. So even though there was drooling and some overstuffing, they reported that they didn't have problems actually swallowing. And then 24% of that did report issues with swallowing and aspiration. So my part was really short. I mainly just did the data. So now I'll hand it over to Beth Nutt. These are really strong clasps.
Okay. My part, I'm going to talk a little bit about resonance and apraxia in these children. So when we talk about resonance, we're talking about how sounds either resonate through the oral or through the nasal cavity. So in normal speech, the only consonant sounds that should resonate through the nasal cavity are the M, the N, and the NG. Okay, those are where the palate relaxes down so that sounds can come through the nose. All the other consonant sounds in our speech, the palate has to close back tightly against the back wall of the throat, which is essentially sealing off the floor of the nose so that the sound can come through the oral cavity. Oftentimes children with cleft palate may have some issues with what we call hypernasal resonance, which means too much air is coming out the nose during those oral consonants. Sometimes we also will see nasal air emission, which means it can be audible. We could hear the air, or if you put a little mirror under the nose, you could see it fogging up on the mirror on those sounds besides M, N, and NG. So we notice that sometimes in children who've had a history of cleft palate, even after the palate is repaired, the cleft is repaired, sometimes the palate can still be a little short, and so maybe it just can't reach far enough to make that closure. Other times we see sometimes in apraxia, we see some hypernasal resonance. Sometimes that can be fluctuating, and often that's due to a timing issue with the motor plan. So with the children that we saw last year, and of course our goal is to this year analyze all the data on the children that we saw this year compared to last year. So hopefully we'll have a bigger base next year to compare all this to. But for the children that we saw last year, for the 38 children, 66% of them had no cleft, no identified cleft, and 34% did have a cleft palate. And I think all these children, it was not a submucus, it was the open cleft that had been repaired. So when we were looking at resonance in the children that were primarily verbal communicators, because it's very difficult to assess resonance if you're not talking enough to really know, okay? So in the children that we saw, 73% in the primarily verbal communicators, 73% we judged to have normal resonance perceptually, just from what our ear heard. There are objective measures that you can do to assess resonance, but in the scope of our short clinic visit, that just was not an option. But there were 10.5% we judged them clinically to have some mild hypernasal resonance, and 15.7% we judged to have moderate hypernasal resonance. But only 2 of the 5 children that we were concerned for possible VPI, which means veloparyngeal incompetence, had a history of cleft. So the apraxia might be explaining the hypernasality in the other ones that we perceived as hypernasal. And then apraxia is a really big part of this population syndrome. Last year when we went into this, we didn't really know anything other than what we read on the website and what Dr. Zarate shared with us about the speech in these children. But from everything we read, apraxia was a big concerning reason for why these children had great difficulty developing functional verbal speech. So just as a background, apraxia is a motor planning speech disorder, so it's not a developmental speech delay. It's not going to just get better with time without direct instruction. And there's varying degrees of apraxia. Some children with intensive therapy will be able to develop functional verbal speech. Some children may be able to make great improvements in their verbal speech, but still not sound like you and I sound. And then there are some children that functional verbal speech is their primary means of communication, may not be as possible. Okay, that's what we're still trying to figure out with these children. They have difficulty with the motor plan from the brain telling the mouth how to move to the tongue, how to move the lips, how to do all this in coordination. Before I've been a speech pathologist for 30 years, but I never really thought about how I learned to talk, okay? And you probably didn't either, you just talk. We don't remember learning how to talk, and learning how to talk is a very complex motor plan. I mean, we just don't think about the complexity of it. But these children often have very inconsistent productions. Imitation is very difficult for these children. They have unexpected errors, not your typical speech substitution errors. They have lots of omissions of sounds. Maybe they can do short 1-syllable words, but you do a 2-syllable or a 3-syllable word, and it becomes much more difficult. We see lots of vowel errors with these children sometimes. Vowels are the simplest motor plan in speech. So when you see a child who has difficulty with production of vowels, sometimes that can really send us a red flag for a motor planning disorder. As the complexity increases for these sounds in words, then children have more and more trouble. You probably saw some of us in clinic. We would have your child try to repeat like some 3-syllable, 4-syllable words. And we didn't do that with a lot of children because a lot of them are just not at the level where they could do that. But when we were doing that, we were not necessarily looking to see was their production articulated correctly with every sound. But what we wanted to know is did they consistently say the word the same way across 3 trials, okay? So as the length of utterance increases, they have more difficulty. So for the children that we saw last year, and I feel like real similar trends we're going to find with our data this year, is that 53% of the children had a diagnosis of verbal apraxia or strong characteristics of apraxia. 47% had just limited verbal speech to assess for apraxia characteristics. So what that tells us is that a lot of the nonverbal children that we saw where nonverbal communication is their primary means of communication, it's just really hard to know if, definitively about apraxia with them, but most likely that's a strong indicator for why they're having great difficulty developing speech. One thing that really stood out with me with clinic this year is that I also think a lot of these children have oral apraxia. So verbal apraxia is when they have difficulty with production when speech is involved. Oral apraxia doesn't involve speech production, but involves movements of the oral structures. So when we were doing oral exams and we're asking the children to try to move their tongue side to side or open their mouth and try to say ah, a lot of times, kids just don't want to do that, and we get that, okay? They've had people looking in their mouth all day. But for some children, you could see they were really, really trying, and it was just hard. So some groping things. So like if you asked, for an example, if you asked a child to maybe pucker their lips, and they have great difficulty doing that, but if you gave them a straw and asked them to drink, they probably could do that fine, okay? It's the same muscle movement, but being able to do it on command versus just in a non-command way, it's more difficult. So when we think about tips that we'd like to give you, and a lot of this is probably things that you've already thought about and your local therapist have talked about, but just to try to get some more information out there, is that we do feel like it's important to continue targeting receptive vocabulary in treatment, because the more their receptive vocabulary expands, that's going to help no matter what type of expressive communication system they're using, whether they're going to be using speech, whether they're going to be using signs, an AA system, whether that's a PECS picture symbols or board, or whether that is a fancy electronic speech activated device. So we can't ignore that receptive, because just what Ashlyn was saying, compared to their age level peers, their receptive is not where it should be. But for a lot of your children, they do understand a lot more than they can express. And I had a lot of you tell me that, and we see that. And oftentimes they may understand routine things like in daily activities, like you say, go put this in the trash can or things, but we need to continue expanding their receptive language for more abstracts and making those connections to pictures and symbols, those types of things. When it comes to educational planning for your children, we strongly feel that nonverbal IQ testing should be considered with these children, because when the slide earlier, when I showed you that the majority of these children are either going to go the path of nonverbal as their primary, that doesn't mean they don't use any words, but they're not using enough words that's their primary way to let other people know what they want and need, and just from an educational standpoint, what they know, okay? And then if they're not nonverbal, then they're going to probably follow the path of apraxia. We didn't see any children in clinic last year that were primary verbal communicators who were not apraxia, okay? So I think the underlying thing is that you assume they're going to be apraxic as far as how you go about treating the verbal speech, okay? That you don't want to waste time doing just traditional developmental speech. So that was my next point, assume apraxia in therapy, okay? There's nothing that you would do in working with apraxia therapy that's not going to be helpful to any child who has a speech problem, okay? So you're not going to do any harm, even if this child, okay, the more children that we see, if we find, well, some of these children are verbal and they don't have apraxia. Working from an apraxia standpoint is going to cause no harm to the child. Implement AAC from the beginning of therapy. We can't wait till these children are 5 or 6 years old before giving them some type of AAC system. So in the very beginning, it could be just gestures. It could be hand over hand gestures, you guiding them. A lot of times parents say they take me to what they want, okay? That's communication. Sometimes we just think those things are just behaviors. Those are communication, okay? So gestures. Then if they're developing early sign language, one thing I shared with a lot of the parents that I saw who were doing sign language is that it's important to remember it's not like we're teaching ASL to a child who's hearing impaired, that we want the exact sign to be perfect every time, okay? When you're using sign language, it's kind of that bridge to functional communication. It's not about the sign being perfect. It's just about it being something that's a consistent symbol that the child's using all the time that's more functional than just Okay, so you're doing a higher level of communication. But, you know, these children, there's not one exact, because sometimes I've had some of the parents say, well, what do you think is the best AAC system for my child, okay? At this point right now, we can't say there's one that we feel is the best for your child, okay? I think there's lots of different avenues. What we do feel is that it has to be a part of that treatment, okay? Because what we want is for your children to be functional communicators like everyone else. Just because they're not verbal all the time doesn't mean they're not functional. One thing I loved yesterday with a family that I saw, that when this child was using a board, and I loved that the family said, use your words to tell me what you want. And the child is going to point to the symbol on the board, but those symbols are her words. Okay, so I loved how they said that. And so I think that's a great takeaway to think about when you're using signs or words or whatever. Like, use your words to tell me what you want. Watch for signs and symptoms of aspiration. One thing we noticed in clinic this year, like when you saw that slide, it was only about 26% that reported difficulty swallowing. One thing we saw in this year, I'm going to be real curious with the data this year to see if that number is a little elevated, because I had more parents, for the ones that I saw, and I think my partner Kieran saw the same thing, is that some of these children, we saw a lot more report of choking on foods than liquids, necessarily aspirating liquids, okay? So be aware of that. If your child is chronically having respiratory illnesses and is not getting better, don't assume that it couldn't be related to aspiration. Just because your child doesn't cough when they drink or eat, silent aspiration can be an underlying thing. The good news about drooling is that often we're seeing that's improving over time, okay? I had some parents that say, yeah, it's better, he doesn't have to wear a bib anymore, okay? So that's always a good sign when you're graduating from the bib, or it's like, no, his shirt's not staying wet all the time. And then to know that if you're noticing any hypernasal resonance, and it could be from BPI related to the cleft, or it could be just a motor planning issue related to apraxia. So those are our big findings that we saw last year, and then hopefully we'll be able to compare that to see what we found this year, to provide some more information about how these children communication and feeding progresses, and what's going to be helpful for them. So now we'll turn over any questions.
I was curious, did you hear anything from parents about words disappearing again? Children being able to say certain words and then later on losing those words?
I do recall last year a few parents reporting regression. Regression is something that we hear a lot of times from parents of kids who have an autism spectrum disorder. And so there may be some connection there, but I did hear from some parents, he used to say 5 words and then he drops them off. He's lost some words that he had, and now he says a couple more. I can't say that was across all kids, but it is something that I did hear. What about you, Beth?
I didn't hear a lot of that that I remember from last year, and not really this year. The big thing I heard more of is how sometimes when we would ask, like, how many words does your child have, or when did they speak their first word, we would hear things like, sometimes he just said this, and it just out of the blue, and never said it again, okay? That to us is more really related to the apraxia, okay? You might see that in autism, but that's a real, sometimes with apraxia, and they're like, Well, if he can say banana perfectly clear this week, why, and never say it again, why can't he say it? So sometimes when words just pop out of the blue, and I believe parents when they say that, because we've seen it happen, okay? They can clearly say this complex word, but they can't say no. Okay, so to us, that's more, that's just, that child really doesn't have volitional control of that word when they're saying it. For some reason, it just pops out clearly, but if you ask them to say it again, they're probably not going to be successful with it. Does that make sense? I'm not sure if that totally answers your question.
Hello.
Hello.
Do you guys have any recommendations for resources, for ideas on things to help them learn how to develop their muscles with the apraxia, that kind of thing? Any recommendations?
That's a great question. With apraxia, there's a lot of kind of things out there on the internet that sometimes when people talk about we need to strengthen the muscles, and they'll say we need to do these oral motor exercises or different types of things. That's strengthening the muscles is not, muscle weakness is not the problem in apraxia, okay? So doing exercise to strengthen the muscles is not really gonna help their speech. What helps their speech is to practice speech, okay? Now, that's not to say that we don't use different tools and things with children to help provide that multimodality feedback and cues. I've worked with a lot of children with apraxia through the years in therapy. Now, I've not had the opportunity yet to work with a SATB child who has apraxia, but just I've worked with a lot of children who've had severe apraxia. And there are times when I might use, if I was trying to work on getting them lip closure for like P's or B's or M's, and they don't know how to do that, or they don't, because if a child could just say it just by watching me and repeat it, they probably don't need to be in therapy, okay? If it was that easy, you could fix it at home. But sometimes what I do, I might take a tongue depressor, and I might put, like flavored chapstick on each side of the tongue depressor, have the child like hold it between their lips to get that feel, because for some reason they don't know how to go, but like it doesn't make sense to them, okay? There's other cueing strategies, different tools we use. Sometimes we've used horns to try to elicit a certain placement of the lips, but any kind of tool that you're using, it's not that if your therapist tells you it's for the purpose of strengthening those muscles to improve for apraxia, it's probably not going to be of the greatest benefit. Now, if you had a child who had muscle weakness, then certainly exercises can be helpful. Is that very helpful to you? I'm sorry, what? Online references for the apraxia? Yeah, I can get you some information. Yeah.
My daughter lately is really intrigued with just like playing with her tongue, looking in the mirror. Is she becoming more, is she feeling it? Because she can't even kiss. Like it's just a slobber.
Right.
So she has like severe oral apraxia. And we've tried and tried and tried.
Yeah.
But what would you suggest? What is this new tongue fascination? Anything sounds familiar? No?
I mean, it could be that she's exploring. I mean, it could just be she's just doing, like not purposeful movement. But it could be, I mean, I always try to attach some kind of meaning with anything a child's doing, even if I think it's not for purpose. Just like if a child blurts out a sound, like try to attach something meaningful to that. So is she doing just kind of like side to side, or just different ways?
Like just totally like looking at it and
Yeah.
crazy stuff. So
Yeah.
I didn't know if that was an apraxic thing, that maybe as she's aging, she's starting to put those two and two together.
Possibly. I don't really know the answer. I'm sorry.
I didn't know. Okay.
Okay, they're asking things I don't know. Is there another?
A different microphone.
Yeah, I don't need that microphone, but so I don't know if this pertains to a lot of other kids. My daughter was also diagnosed with hypothermia, and so So kind of my question is, if most of our kids also have apraxia, obviously that's something I want to be on the lookout for. Is there a way to discern the difference?
I mean, it can coexist with some. I mean, what we saw is a lot of these children have a diagnosis of hypotonia, so you've got some low muscle tone, but I don't think that that would be the primary reason why they're so nonverbal. I think if it was just from low muscle tone, they might sound more just dysarthric, so their speech is kind of a little slurred or maybe prolonged. But it's probably more the apraxia that's causing that. Now, there are some oral motor things that sometimes with drooling, that if you've got your kids who are drooling. So I didn't mean to imply earlier that it's totally, but for the apraxia, the oral motor strengthening is not going to be your best thing for improving speech. But I think we do see it a lot. And I should have mentioned the hypotonia earlier when you said that.
Hi.
Hi.
I know that you answered our question at the clinic visit yesterday, but I just wanted to ask this for the people that are not here, I guess. And
Okay, let's hope I remember what I told you.
No, that's all cool. So basically, we struggle to get enough speech therapy back home. So what is your recommended speech therapy sessions per week
Right.
or per month for
Yeah.
a kid like ours?
Great. So we talked about this a lot. This is Naomi, right? Yeah. So, there's not a flat answer for how to answer that, okay? So I kind of, when I was talking about with Naomi, I said, if a child just came to my clinic and I only diagnosed verbal apraxia, let's say they don't have SATB2, they don't have major receptive language, but their expressive is probably delayed because they have verbal apraxia. So my recommendation typically with that child would be a minimum of 90 to 120 minutes a week, okay? That is not an excessive recommendation at all. When ASHA, which is the American Speech and Hearing Association, which is our governing body for speech pathology, if on their website, when they talk about apraxia, there's things where you can go to where it talks about reference some of the research, and they really recommend more intensive therapy early on. Shorter sessions held more frequently is going to be of most benefits to apraxia children than, say, doing, if you could only get 2 hours of therapy a week, well, it would be better to break that down into smaller sessions than just 1 hour twice a week, okay? So that kind of is a minimum that I think about with these children. And so when I look at your children who not only have, a lot of them have apraxia, or they're nonverbal and they're working on AAC communication as their primary means of communication, they may also have some feeding deficits, plus they have receptive and expressive language delays. You combine all that together, and they don't have a functional, established, successful way to communicate maybe with unfamiliar people yet. They're great with you because your job as parents is to know what they want and need, and so you're often able to anticipate and know that from the beginning. But in the school or with unfamiliar people, that's going to be a lot more challenging. So that's why I would say a minimum 90 to 120 minutes, and probably most of your children would benefit more, okay? I think it was very interesting hearing, because that's one of the questions that we asked is how much speech therapy does your child receive every week? Some of you are fortunate that you're able to get therapy at school as well as privately. Some of you are struggling to get any therapy at all. Some of your kids are stuck in group therapy versus the individual one-on-one. So there's a lot of challenges to face, but I think when you're in those IEP meetings, you've got to really, fight for what you need, and probably, in some situations, we can't always depend on the school or the state agencies to provide what your child needs, because in the schools, they're going to provide what's educationally appropriate, and that might not be what you think is optimal. I will say, if you're, if somebody set a recommendation with all those different deficit areas, if they say 30 minutes a week is sufficient for your child, that's probably not okay. in my book, because our goal is you want your child to be a successful communicator. That doesn't mean that everyone can be a successful verbal communicator, but your children can learn to be successful communicators with whatever modality is going to be optimal for them. I'm talking too much.
No, it's okay. I believe, did you have a question there in the yellow? She had her hand up and kept putting it down. I didn't want to miss her.
Hi. My son David uses the iPad primarily for his communication, and he does really well. And David did not like going to speech therapy at school at all. It was like the last thing he wanted to do on his own. He was scheduled for group therapy, and even that, he was not excited about going. However, when he saw the other kids going, there were times that he would just want to go. And he was really fortunate that, and you might want to ask your speech therapist at school for your children if he or she could tag along, because it's great for the other kids to practice with another child, and David would not necessarily answer speak with them, but it was great practice for him on his iPad, and he really enjoyed it, and it made it fun for him. It also made it fun for the other kids. In a lot of the schools, they really want to do this group therapy time. So our speech therapist, she said she loved David. Your kids, they're really, really friendly. They're loving. They were really open to having him just come along, and you might want to put that in if you can get more time to pop on in, because he was able to go whenever he wanted. So.
That's a great suggestion. And I think when you think about having, it's difficult to do AAC in a one-on-one kind of, you have to have two partners, so the therapist, but sometimes communicating with adult versus communicating with an age-level peer, whether you're verbally or whether your language, it's different. It's a different mode of communication. So I love the idea of having a normal communication peer tagging along in therapy. That's a great suggestion.
Okay, my question real quick. It's a request, more actually. After the IEP session yesterday, I had a lot of parents asking about if some professionals could put together a letter that they could take to the school that says, based on evidence-based research, this is what is appropriate, this is what is not appropriate for a SATB2 child with severe apraxia of speech. Would you all be able to create something like that for us to bring to our schools?
Yeah, I think based on the information that we're finding from last year and this year, that now that we know that what the significant, and then in conjunction with what ASHA, our governing body, says, I think that's something that we could work towards for sure.
Awesome.
I'm just curious from a research standpoint, when you guys were putting all of your information and facts together, did you look at any of the information on children with seizure disorders and which are nonverbal and which are verbal?
That's not a question that we were able to answer. Sometimes it was hard to find in each child's medical record, since we were relying on outside records regarding their neuro background. To have all of that, that's a question that we sort of considered as we found that there were several kids in SAS Clinic who had seizure disorder, which is obviously going to have an impact on their neurology as a whole, particularly when it comes to some intellectual disability. So that would be a really interesting question, but some more data that we would need to have from their neurologists and so forth. There's such a wide variety of functioning when it comes to kids who purely have seizure disorder altogether.
I don't want to take much of time, but Dr. Z does have my story on this with Sylvia, our daughter, who did have an undetected seizure disorder. And once we started treatment with her, it was within a couple of weeks that she was able to say her first word and hold her first word and continue to build language. And we've seen that. And last year we had a little incident where her medication was changed unknowingly. And for a week she went completely nonverbal. So it was almost a test for us. So it is, for me, that was something
It's huge.
I was really curious about. Yeah.
Absolutely. And in kids without SAS, I mean, you just see so much impact when it comes to speech and language and cognition. And so that's a big piece of the puzzle that we haven't explored, but very significant, as in with Sylvia's story.
So you touched base on feeding a little bit. Like my son, for example, he's tube fed. He aspirates, has dysphagia. We've been doing the vital stem therapy since he's been about 10 months old. Is that a recommended therapy for these feeding issues? Are you guys familiar with that? Because I know speech and feeding are your finest fine motors, so they do go hand in hand.
So this is controversial. I'm going to start off by saying that. So Vital Stem is not an evidence-based, we don't have a good evidence base for how it impacts pharyngeal dysphagia for children. So Vital Stem stimulates muscles generally in an adult population post-stroke, post-TBI. And so it's to re-innervate these muscles. The pharyngeal dysphagia that we generally see in a pediatric population isn't necessarily muscular. Okay, so we have cartilages that protect the airway. So in the swallow studies that we see, that we do at the hospital, the majority of those kids have trouble with the cartilages that protect the airway, either because of reflux or from those cartilages being floppy from birth. We also see kids with neurological disorders who have trouble closing that cartilage on time. It's not that they're weak. It's just a mistiming altogether. And so innervating those muscles with that outside electrical stimulation doesn't have much face validity when it comes to Vital Stem. So Vital Stem isn't used much with peds, and it's very controversial. I don't want to throw the baby out with the bathwater and say that a child who also has low tone can't benefit from innervation of their muscles with Vital Stem, but that's not something that we do here at Arkansas Children's. Beth, anything to add on that?
No, that's kind of
All
how
right.
I practice right now. So thank you.
All right, thank you so much.